Okay, so this is a plain X-ray of chest showing um, diffuse bilateral opacities
All
in the
right.
long field.
Okay. So, can you define ARDS?
Okay, so so it is the acute inflammatory injury to the of the lung parenchyma and epithelium, resulting in the hypoxemia and and, and PC WP per capillary with pressure of less than 18 and partial pressure of oxygen less than 60.
All right. We'll come back to this one. Now, tell me the pathophysiology of the acute respiratory distress syndrome.
Okay, so there is two phases: acute inflammatory phase and chronic phase. In acute phase, there is damage to the alveolar epithelium and damage to the capillary endothelium. Damage to capillary endothelium leads to leakage of the fluids and causes the obesities. And damage to alveolar epithelium leads to dysfunction in diffusion of gases and hypoxemia.
Okay.
In chronic, the inflammation heals with fibrosis and scarring.
All right. So, can you tell me about the causes of the ARDS?
Okay, so after post-operative, after it might be due to sepsis, pancreatitis, and mm,
All right.
I
Okay,
can
no
I will
problem.
get back to this
We
later.
will come back to this. Tell me about the investigation of ARDS.
Okay, so first of all, I would like to investigate the patient with. I will send the blood, and in blood, I'll look for hemoglobin, urea, and electrolyte, and renal function test and liver function test. And I would like to order a chest X-ray and a CT scan of the chest, and also I would like to do a ABG, arterial blood gas analysis.
Okay. So, what is Berlin criteria?
So um, it is defined. It defines the ARDS severity, which is mild, moderate, and severe, in which we see the partial pressure of oxygen and functional respiratory oxygen ratio. In mild, it is 200 to 300. In moderate, it is 100 to 200, and in severe, it is less than 100.
Okay. So, what is the management of this patient?
Okay, so I will manage the patient according to the care of critical ill surgical patient protocol following ABCDE. After confirming the airway patency, I will move to the breathing support. In respiratory support, uh, uh, I will ventilate the patient with low tidal volume and low PEEP, positive end expiratory pressure, and I will position the patient in prone position. If these matters, if these measures are not helping, then I will do a extracorporeal membrane oxygenation, and also I can give various pharmacological agents like low dose steroids, IV antibiotics according to local trust policy, and prophylaxis of DVT,
Okay. What else?
and nutritional support with enteral nutrition,
Okay.
and also and then in circulation I will uh, introduce a large wide bore cannula in the central venous line, and monitor the central venous pressure, which should be kept in low range.
Okay. So, what is the sequelae of acute respiratory distress syndrome?
Okay, so there will be decrease lung compliance, and in the long run, there might be a ventilation and perfusion mismatch, and also there might be shunting, and on the long run, there is also pulmonary hypertension.
Okay. So, Dr. Savlin, can you please mention what he missed in the management of respiratory support this patient?
Uh, Sir, there can be invasive ventilation, and also we have to keep the patient prone.
All right.
Actually, there
So,
are multiple. We have to follow the lung protective strategies. Sir.
okay, remember, all right. I'm going back to the station as a whole, all right. So, for the definition of acute respiratory distress syndrome, acute respiratory failure and non cardiogenic pulmonary edema. It will lead to
Edema.
hypoxia and decreased lung compliance refractory to oxygen therapy. It is characterized by the diffuse pulmonary infiltrates, the pulmonary artery wedge pressure less than 18, and the PaO2 by FiO2 ratio is less than 26.6 kilopascal or less than 300 mg.
Okay.
Remember this definition. They will ask you, this is important. What is the pathophysiology, acute versus later reparative phase? So in the acute phase, what Dr. Prabhat mentioned as it is. In later phase, it is characterized by fibroproliferation and organization of the lung tissue. It may lead to what scarring and sensitive fibrosis. Or now about these causes, remember divided into two. We have direct lung injury and indirect lung injury. For the direct lung injury, it will destroy the type 1 cells. So, trauma, pneumonia, gastric aspiration, pulmonary embolism, near drowning, and environmental exposures. For the indirect lung injury, we have acute pancreatitis, burns, sepsis, massive transfusion, and transfusion-associated lung injury, the trolley. All right, and then drug toxicity. Remember, these are very important questions they are asking. They will ask you how will you investigate for acute respiratory distress syndrome according to the cause. Okay, according to the cause. So, for pneumonia, we can go for the baseline investigation, chest X-ray, CT scan. For atelectasis, we can go for the serial chest X-ray. For the pulmonary embolism, we can go for the CT pulmonary angiogram beside the arterial blood gases level. And for the pleural effusion, again the CT scan, ultrasound, or the chest X-ray. Now, for Berlin criteria, what Dr. Prabhat mentioned as it is, for the management, it's a very important. Respiratory support, remember, low tidal volume, moderate PEEP, chronic position, high frequency oscillation, and inverse ratio ventilation. If this will not improve the patient, then we will go for the extracorporeal membrane oxygenation. For the pharmacological support, remember, we can use low dose steroids. We can use inhaled nitric oxide or prostacyclines, and antibiotic according to the local trust policy. Now, for the hemodynamic management, we will keep the CVP within 2 to 8. We will use the fluid cautiously. And if there is fluid or like if there is increased fluid level or if there is edema, then we can go for the what? We can go for the diuretics, okay, furosemide, remember.
Diuretics.
And if the patient is like, if there is evidence of circulatory failure, we can go for the dopamine or the inotropic support. For the nutrition, we can use low carbohydrate and high fat formula, and we will be using PPI to prevent the gastric ulcers. Now, what are the sequelae for ARDS? What Dr. Prabhat mentioned as it is, okay? Impaired gas exchange, pulmonary hypertension, decreased compliance. Remember, this station is very important. It's coming in the exam as a separate station or with in combination with the pulmonary edema, all right, for ARDS. Now,